All right, welcome to Tinkle Topics. Yes, that's what I'm calling it. We're going to dive into pediatric genitourinary disorders. These are conditions that deal with the urinary system in children. Think of the urinary system as the body's plumbing. Its job is to keep everything flowing and balanced. And when things go wrong with this plumbing, kids can experience a variety of symptoms that affect both their health and their confidence. Let's look at some of these disorders. First up is enuresis. While the term might be new to you, likely you've already been exposed to this and you know what it is. Enuresis is the medical term for wetting. This is when a child is old enough to have bladder control but still has unintentional urination, especially at night. It's important to remember that this isn't just about accidents. It can be a big deal for the child's self-esteem. We have to rule out other causes of enuresis like anxiety, constipation, diabetes, UTI, or even a small bladder. There are two types of enuresis. Primary, where the child has never been dry at night or during the day, right? Never gotten control of the bladder. And secondary, when they start wetting again after having bladder control. So the child's been potty trained and then regresses. Think of it like computer software. Sometimes the system never gets an update, like primary enuresis, and sometimes it got the update, but then a glitch erases it, like secondary enuresis. Risk factors for enuresis include being male. Males have a harder time getting that bladder controlled. Having bladder dysfunction, experiencing emotional stressors like divorce or having a new sibling join the family, or having a behavioral disorder. When it comes to diagnosis, providers will do a physical exam, check urine and blood tests, and sometimes look at bladder capacity. A quick formula for bladder capacity is to take the child's age plus 2 up to about age 14. So if a child is 6, the bladder capacity would be 6 plus 2 would be 8 ounces, a cup of juice. If they're voiding much smaller amounts, we know the bladder isn't stretching like it should. Our role as nurses is to protect the child's self-esteem. We want to normalize it. No shaming. Education is key. Encourage them to urinate before bed. So hopefully going to bed with an empty bladder will decrease the amount of nighttime wetting. Restrict fluids 2 hours before sleep and avoid caffeine later in the day because caffeine is a diuretic. Positive reinforcement works wonders. Think sticker charts for dry nights. That being said, a lot of times the children aren't waking enough to actually get up and go to the bathroom. So sometimes the positive rewards aren't as effective, right? Kids also can be involved in their care, like helping to change the sheets. That way, it's a shared responsibility with no punishment. Again, no shaming because it's usually going to be outside of the child's control. They're not waking up enough or they're not able to control the bladder like they should be able to at that age. So, therapeutic measures for enuresis. Some therapeutic measures include reward systems, Kegel exercises, which help to strengthen the pelvic floor and improve bladder control, and waking the child to void on a schedule. Conditioning therapy uses urine alarms. Basically, if moisture is detected, the alarm, which is under the sheet, goes off. It wakes up the child, who's able to sort of stop midstream and get up and use the restroom. Medication include desmopressin, which acts like an antidiuretic hormone. Antidiuretic meaning antidiuresis, anti-urination. Tricyclic antidepressants for older kids, and sometimes anticholinergics like oxybutynin chloride. Oxybutynin chloride, the anticholinergic, will help to relax the bladder. And don't forget about the emotional piece. Kids may feel embarrassed, isolated, or even scared, so supporting their self-image is an important part in the treatment of bedwetting. UTIs, not a new concept for you. You've learned about UTIs already, but we'll talk about it a little bit in relationship to the pediatric population. First, we'll look at some terms that you may or may not be familiar with. Cystitis would be inflammation of the, hopefully you said bladder. Urethritis, I'll get it sooner or later, inflammation of the urethra. And lastly, pyelonephritis, oftentimes heard clinically, you just might hear the provider talk about Pyelonephritis would be inflammation and infection of the kidney, okay? UTIs are really common in pediatrics, especially, what do you think, boys or girls? Especially girls. Risk factors include urinary stasis, which would be anytime the urine isn't moving forward and is just kind of stagnant. Constipation, toilet training. Maybe they're not emptying their bladder when they're learning how to use the toilet. Being uncircumcised, bubble baths, sexual activity in adolescence, catheter use, and even diabetes. In neonates, UTIs don't look like the classic burning with urination that adults describe. Neonates, infants, they're not able to describe those symptoms. Instead, they may have poor feeding, vomiting, jaundice, or even low temperatures. Infants under age 2 may have vague symptoms like fever, irritability, foul-smelling urine. Once kids are older, we see more textbook-style symptoms: dysuria, urgency, hematuria, suprapubic pain, or even flank pain if it's pyelonephritis. And flank pain would be a spot on the patient's back about the location of the kidney. Always remember, fever without a clear source in a child, you want to think UTI until proven otherwise. Testing for UTI includes a urine dipstick, where we can look at things like the appearance of urine. Is it cloudy? And the dipstick will tell us if the urine is positive for leukocyte esterase and or nitrates. A positive leukocyte esterase and or nitrates is pointing us towards a UTI. A urine culture is the gold standard. For little ones, a sterile catheterization is best, since bagged urine samples are easily contaminated. And the number one bacteria? Good old E. coli. Sometimes imaging is needed as well, like an ultrasound or a voiding cystourethrogram to check for anatomical issues. One anatomical issue that a child might have is vesicoureteral reflux. And reflux would mean something going backwards. And in this case, it would be urine from the bladder going back up into the ureter. Vesicoureteral reflux, when the bladder contracts and some urine goes back up into the ureter instead of down the urethra and out, causes urine to stay in the bladder, right? It'll end up coming back down into the bladder that would have otherwise been voided out. And that urine not being processed out in a normal manner, right, staying in the body longer than it should be, that urinary stasis increases the risk for bladder infections, also known as cystitis. Nursing care includes encouraging fluids, frequent voiding, and monitoring I's and O's. Pain control and antibiotics are based on culture results. Education for families is huge. Wiping front to back, avoiding bubble baths, wearing cotton underwear, and encourage voiding after sex in adolescence. Also teach about hydration and avoiding constipation, which can trap urine. Left untreated, UTIs can cause long-term kidney damage, so early recognition is critical. Complications of UTIs include progressive kidney injury, which could lead to long-term kidney damage, pyelonephritis, and urosepsis.